We are discussing germ cell tumors of the ovary, and amongst that, teratomas. Teratomas are divided into three main categories. Number one, mature teratoma, which is benign teratoma, immature teratoma, which is malignant teratoma, and monodermal or highly specialized teratomas. Mature teratomas, which are benign teratomas, may be cystic or solid. Most benign teratomas are cystic and are known as dermoid cyst. They are one of the commonest ovarian tumors. Cystic teratomas are usually found in women during active reproductive years. Mostly they are asymptomatic, but patient may present with abdominal swelling, pain, or uterine bleeding. They are accidentally found in an ovarian specimen, or they are associated with an important paraneoplastic syndrome such as inflammatory limbic encephalitis, which cure upon the removal of the tumor. Benign teratomas are bilateral in 10 to 15% of cases. They are smaller than 15 centimeter in size, may be multiple in one ovary. Combination of cystic and solid masses with white to grey external surface. Mostly they are unilocular cyst. Once they opened, the cyst may contain visible hair, cheese-like material, which is sebaceous material, skin, bone, cartilage, fat, thyroid tissue, brain tissue, and sometimes teeth. Microscopic features. The cyst wall is composed of stratified squamous epithelium with underlying sebaceous glands, hair shafts, and other skin adnexal structures. Mature type of tissues, which are representing all three germinal layers, often consist of ectodermal tissue with a cyst lined by mature epidermis and its appendages, and one can find rare mitosis. Neuroectodermal element, which is composed of glial tissue, peripheral nervous tissue, cerebrum and cerebellum. Mesodermal element like smooth muscles, bone, teeth, cartilage and fat may be present. Endodermal tissue include respiratory and gastrointestinal epithelium along with thyroid tissue. Then the dermoid cysts are sometimes present within the wall of a mucinous cyst adenoma. Immunohistochemistry is not very significant and corresponds to the tissues which are present. About 1% of dermoid cysts undergo malignant transformation. For example, one can see thyroid carcinoma, malignant melanoma, but most commonly is squamous cell carcinoma. Dermoid cysts are lined by keratinizing squamous epithelium with dermal appendages. Skin may be admixed with struma ovarian carcinoid tumor or solid teratoma, or they may be a foreign body type of giant cell reaction. Dermoid cyst may be present in the contralateral ovary in patients with yolk sac tumor or immature teratoma, which is seen in about 5 to 10% of cases. Treatment is cystectomy. This gross photograph of dermoid cyst shows that its wall is thick, it is multiloculated and contains hair along with piece of bone. This photograph shows histological features. There is keratin material, stratified squamous epithelium, fibrous tissue, hair shafts, sebaceous glands, fibrous tissue, and neural tissue, which are present in varying amount. The karyotype of all benign teratomas is 46XX. It is suggested that tumors arise from an ovum after the first meiotic division. Mature solid teratoma. They are uncommon, slow-growing, benign tumor with a peak incidence in first and second decade of life. Usually they are asymptomatic until they are large. Gross features: they are unilateral, large, mostly solid with minimal hemorrhage or necrosis. Microscopic features: When a benign teratoma is solid, it is mainly composed entirely of a benign-looking heterogeneous collection of tissues and organized structures which are derived from three germinal layers, meaning thereby the structures are derived from endoderm, ectoderm, mesoderm, but these teratomas are solid. Sometimes neural tissue is in an excess form and there are only rare mitosis. Again, I'll stress thorough sampling of the submitted tissue is required to rule out immature teratoma. Immunohistochemistry is not specific. Monodermal or specialized teratomas, stoma ovary, they are always unilateral, although a contralateral teratoma may be present, seen mainly reproductive years and mostly usually asymptomatic. Some of these patients may present with a painful mass, swelling or ascites. Uterine bleeding has also been reported, occasionally associated with thyrotoxicosis and thyroid enlargement. Gross features, they are unilateral, normally less than 10 centimeter in diameter. They have smooth surface. They are solid, brown or green brown, glistening tissue separated by fibrous septa with or without an associated mature cystic teratoma. Fluid-filled cysts containing brown to green gelatinous material are also present. There are hemorrhages, necrosis and fibrosis are also seen. Now, microscopic features, they are composed of mature thyroid tissue with variable sized thyroid follicles lined by a single layer of columnar, cuboidal or flattened epithelium, follicles with colloid mixed with solid cellular areas, and sometimes there are cysts which are present. Thyroid adenoma may be present. Oxophilic cells, clear cells and solid tubular forms are present. Changes like that of the thyroid gland, including thyroid hyperplasia or thyroiditis, is also a feature, but carcinoma is very, very rare in stoma ovary. Immunohistochemistry, PS positive colloid material can be seen. Thyroglobulin highlights thyroglobulin in the stoma component. Ovarian carcinoid. It may arise from intestinal epithelium in a teratoma and may also be functional, particularly when greater than 7 centimeter in size, producing 5-hydroxytryptamine and carcinoid syndrome. Primary ovarian carcinoids, they are associated with other teratomatous element in 80% of cases. The age is 30 to 80 years in which ovarian carcinoids are present. They are rare tumors forming less than 0.5% of all ovarian tumors. When ovarian carcinoid syndrome is present, they are more commonly seen in older patients. Elevated urinary 5-hydroxy indole acetic acid can be detected. Gross features. They are unilateral, yellow, small tumors projecting in a dermoid cyst. Sometimes they are found in a mucinous cyst or a solid teratoma. They can be seen as a large, homogeneous mass. Microscopic features. The insular carcinoid is common. These are discrete groups of small uniform cells which are separated by fibrous stroma. The cells are uniform with abundant cytoplasm. Nuclei have coarse chromatin and rare mitosis are present. They may be associated with other teratomatous components. Variants include trabecular, stromal, and goblet cell type. Primary ovarian carcinoid must be differentiated from metastatic intestinal carcinoid, which is always bilateral. Even rare is stromal carcinoid. A combination of stoma ovary and carcinoid may be seen in the same ovary. Only 2% of the carcinoid, they give metastasis. Immunohistochemistry, chromogranin, synaptophysin and non-specific enolase positive. Now this is the photograph of Stoma ovary, you can well appreciate thyroid tissue which contains colloid material which is brownish in color. There are thyroid follicles which are lined by flattened epithelium and containing colloid material. Now this is the photograph of carcinoid tumor in the ovary, which shows that cells, they are uniform, have got hyperchromatic nuclei and they are arranged in a single row and sheets. Immature teratomas. They are rare, rapidly growing malignant tumor present during childhood. Tumors, they differ from benign teratomas in that the component tissue resembles that of embryonal or immature fetal tissue. The tumor is found mainly in prepubertal age and in young women. The mean age is around 18 years. No symptoms present until they are large. Then symptoms are related to abnormal or pelvic mass. Serum alpha-fetoprotein, they are raised. The tumors are bulky and have a smooth external surface. On cut section, they have a solid or mostly solid structures, but frequently mixed with small cysts filled with fluid. Gross appearances, they are unilateral tumors and may be up to 18 centimeter in size, showing capsular perforation and adhesion to the neighboring structures. Sometimes they are composed of one or more large cysts with solid areas in the wall. They are soft. The cut surface shows variegated appearance. They often show areas of hemorrhages and necrosis. Sebaceous material, cartilage, bone, and calcification may be present. Microscopic features. There are varying amount of immature neuroepithelium, cartilage, bone, muscle and other tissues. They are made up of haphazardly arranged immature tissue which are derived from ectoderm, mesoderm and endoderm, which are typically mixed with mature element. Ectoderm element is mainly composed of neural tissue, which includes neuroepithelium forming rosettes and tubules, glial tissue and neuroblastic tissue. Mesodermal element include cartilage, muscle and immature mesenchymal tissue. Endodermal element consists of tubules lined by columnar epithelium. All teratomas which are submitted for histological grading, the neuroectodermal tissue is the most common immature tissue identified. Now the grading of immature teratoma, grade 0, all tissues are mature with no mitotic activity. Grade 1, minor foci of abnormal cellular or immature tissue which is mixed with mature element and slight mitotic activity. Grade 2, moderate amount of immature tissue mixed with mature element and also moderate mitotic activity. Grade 3, large amount of immature tissue with high mitotic activity. Immunohistochemistry, well, the most important immature tissue is the neural tissue. So the neural markers chromogranin and synaptophysin, GFAP and S100 protein demonstrate neuroectodermal tissue. As we know that immature teratomas are rapidly growing lesions, they frequently penetrate the capsule and spread either locally or distantly. Stage 1 tumor are particularly those with low-grade histology and have got an excellent prognosis. High-grade tumors confined to the ovary are usually treated prophylactically with chemotherapy. Most recurrence develop in the first 2 years, and if there is absence of disease in this period, there is an excellent chance of cure. This is the histological photograph of the immature teratoma in which immature neural epithelium is present, having hyperchromatic nuclei present in groups, cords and sheets, and at places there is formation of rosettes.